So like I said, we're going to talk about two main topics. One is this issue of psychotropic polypharmacy. I'm hoping that that part of the talk will be about 30 minutes. I'd like to take an opportunity to field some questions or comments right after that for a few minutes, and then to move on to talk about the newer agents. If we have to speed things up at the end, I think it's going to be easier to do that, talking about the newer agents. Hopefully we'll have some additional time for questions and answers at the end. There are some abbreviation keys in the handouts. Those are there for those of you for whom abbreviations that I may have used may not be familiar to you, so you might want to turn to those at times during the talk. I'll try to point out what some of these things mean. If I confuse somebody, please make sure to raise your hand and let me know. So what is this thing we call polypharmacy? Well, the word first appeared in medical literature in 1959, and in psychiatric literature first in 1969. There are various definitions of it. The one here is the 5 medications level. Now that is sometimes also called major polypharmacy. And so not all polypharmacy need necessarily reach the level of 5 concurrent medications. And for the purposes of this talk, I'm going to want to focus also on situations in which we are using 2 or more medications for the treatment of a certain disorder, especially if those 2 medications are from the same class, like 2 antidepressants, 2 antipsychotics, 2 mood stabilizers, and so on. This is a pretty common practice. As you can see, the data here at the bottom of the slide are from New York State Medicaid claims data. Many patients, at least in New York State, and this turns out to be true if you look at things nationally, are receiving simultaneous prescriptions for 3 or more medications, psychotropic medications at the same time. You can see that this phenomena of polypharmacy with psychotropics spans the age spectrum as well. And some people are particularly concerned about this issue in youth. We would keep more guinea pigs alive. And so for whatever else he found out after he did these studies, it was overshadowed by the observation that the guinea pigs that were given lithium actually were quite a bit calmer than the other guinea pigs. So this is well before the FDA, of course, and back in those days you could do things like try some lithium on yourself and then give it to a bunch of patients, which he did with some vigor. And he gave lithium to patients with schizophrenia, with bipolar disorder, and called manic depressive illness, and depression. And what do you think he found? That it was quite effective, especially for people with mania and for some of the patients with depressive phases of bipolar disorder. And so lithium clearly works. It is the most effective mood stabilizer known to man. It's also the most effective augmentation agent of an antidepressant. It's partially effective, but we still don't know how it works. So the fact that we're often shooting into the dark of this mysterious thing in our brain leaves our field uniquely vulnerable to artistic pharmacology and prescribing practices, and also to sometimes rightfully deserved criticism about what we do. So other than these factors involving a lack of a mechanism, so a clear approach and treatment resistance, what are some of the other principal reasons that we involve ourselves in polypharmacy? So the next slide that says 5 clinical reasons for psychotropic polypharmacy is highlighting these issues. I'm using here the example of a 30-year-old man with schizoaffective disorder, depressed type. So imagine that this man presents psychotic. He's not depressed at the moment. And you desire to treat his symptoms to remission, so you properly give him an antipsychotic. But then, because we are often involved in treating phasic illnesses, the depression rises up, and you decide properly to give him an antidepressant. But then, you also become interested in treating his alcoholism and his smoking. So the next thing you do, you get the idea that maybe you'll give him bupropion, but you didn't use that antidepressant, and you start another one. And you've learned about the potential value of naltrexone in reducing heavy drinking, which we'll talk about a bit later, and so you give him some of that. And then he starts to complain that the depression is not quite resolved, so you give him lithium, which would be an evidence-based augmentation. And then he has some side effects, including extrapyramidal symptoms and restlessness from the Abilify. So you give him some cogentin for the extrapyramidal symptoms, but that doesn't work for the akathisia. So you give him Inderal, and next thing you know, you've got a 30-year-old guy on 6 medications, right? Which violates one of my laws that I talk to patients about. You ought not be, ideally, on more medications than you are decades old, which I think is not a bad rule of thumb. It can't always be done, but it's not a bad thing to keep in perspective, especially with patients with soft syndromes, like borderline patients, for example. But there are other reasons. Now, the next slide has, so we're not going to get this back. Can you ask me? The next slide, well, the next slide says other reasons. The following slide has 2 graphs on it. And these 2 graphs are shown to illustrate the uptick in medication prescribing over the last decade or so, and the corresponding downturn in psychotherapy delivery, at least among psychiatrists. Now, psychotherapy delivery has actually remained relatively stable overall, but you can see that there's been a wild increase in psychotropic prescribing and also the number of patients that are receiving 2 or 3 or more medications over this last 10 years. Now, during this same time period, an explosion of psychotropic drugs has entered the marketplace. There have been roughly 30 new medications approved by the FDA for use in mental disorders since 1990. The money spent on psychotropic drugs in the US grew from an estimate of just under $3 billion in 1987 to nearly $18 billion in 2001, and that number is, of course, still rising. In 2003, antipsychotic costs grew about twice the pace of all drugs for general medical conditions. So there is, in fact, a lot of psychotropic prescribing going on, and not all of it is now being driven by psychiatrists. There's been a great wave of activity, which is, I'm not saying these things are good or bad, among primary care doctors. Now, I've got a little quick diversion here, because my question to you is, what is some of this all about? So the next slide that involves the Australian prisoners is that it's something got to be about the economy of all this, right? What is being rewarded in various ways or influenced by market forces? So this little vignette about Australian prisoners from the early 1700s, back then they had the problem of prisoner transport to Australia, which was a penal colony. And what was happening is they would pay captains of ships a certain amount to transport a certain number of prisoners. They didn't care whether they arrived dead or alive, right? And so what do you think happened? Well, about 33% of the men on these voyages died. And the public became outraged, and they did all kinds of things to try to see if they could influence that. But what do you think worked? Well, what worked is when they changed the economy of the situation. They paid captains only for live prisoners walking off the boat. And suddenly the survival rates rose to 99%. So this is a little lesson about what happens when you reward certain things. And I would argue, you might not agree with me, that we are currently heavily rewarding prescribing in various ways over other interventions for mental disorders. Now, the next slide shows just how much money is going into that. As you can see, there's a lot of marketing going on. The pharmaceutical companies spend about $30 billion a year, well, they did in 2005. I'm sure it's much more than that now. And there's been a specific explosion in the amount of marketing that's going on direct to consumers, the DCTA on that slide. That's risen about 500% in the last 5 years. And any of you that watch the evening news probably can't have avoided seeing ads for multiple medications. And how many times have you seen Abilify and Seroquel and others, Cymbalta, for example, now being heavily marketed to consumers? Now, what we know about that, too, is on another slide, but I'll mention it now, is that it works. Because when patients go to their doctors or other prescribers, nurse practitioners, PAs, and they say they want a certain medicine, there's 3 times the odds that they're going to receive a medicine. So this strategy works. And it's a tough problem. And you've probably, many of you that prescribe, and even those of you that try to restrain people from getting access to prescribers have probably experienced this. Now, the next slide, that should say patient attitudes affecting prescribing. Whether as a result of this marketing or less stigma or more convincing evidence of outcomes for medication use, public opinions about prescription psychotropic drugs are more favorable. In the last decade or so, more survey participants thought that medications helped people. Now listen to the kinds of things they think that they help with. Day-to-day stresses, making things easier in relation with friends and family, helped me feel better about myself. And the public expressed a greater willingness to take medications for troubles in personal life, to cope with stresses of life, for depression, for panic attacks. Some of that we'd agree with, right? Especially the depression and panic attacks. But how many of you think we're reinforcing the idea, possibly wittingly or unwittingly, that pills are the solution to ills of life? And that's one of the things I'd like us to think about in our teams, how we can restrain that urge to go along with the flow of that message. That's an opinion. Now, the next slide with the, should be a slide with a frumpy old lady with my cartoons are not in these. Well, we'll get along. So the next slide, other factors in polypharmacy. I think at our worst, we've become a pill-happy society, right? So I want a pill to help me go to sleep, like Ambien. And that's make me tired in the morning, so I'd like something to help me wake up, like Provida, let's say. And then I need something to feel less anxious and depressed, so I'll have some Effexor, thanks. But my mood is still not quite right, so how about if we augment that with Abilify? And then I'm having a little muscle stiffness and restlessness, and along comes the Cogentin and Inderal, and you can see what happens. Now, the other thing that leads to polypharmacy is patients get stuck in transition. Now, we should be able to help with that if we're paying attention. But there are other sort of interpersonal forces that are at work there too. So how's that work? Well, patient is on drug A, and they are not doing so well. So we decide to switch to drug B, but we want to make a crossover, right? We want to increase one, taper the other. Typically with many things, that's the right way to do it. Then the patient starts to feel better when you add drug B, right? And suddenly everybody either forgets or can't get up the gumption to stop drug A. And then they end up on A and B. Anybody have that experience? I certainly have. And sometimes it's very difficult, even if you really know it's the right thing to do, to negotiate with a patient about stopping the drug. They'll literally sometimes beg you not to proceed. But I think we have some obligation to think about that and take that on as we can. Now, the other thing I think we have an obligation to really pay special attention to is this business of treating symptoms with drugs and not syndromes. We've got an awful lot of that going on. And some people have argued that industry is now in the business of creating diagnosis for which then drugs are developed. Right? Soft bipolarity, for example. Right? Adult ADD, not that there isn't a lot of that in the population. And so it seems like we should be able to avoid giving patients antidepressants simply for crying or grieving, right? Or a mood stabilizer just because they're edgy and irritable. I personally don't think we should be doing that, but I know that there's a lot of that that is going on. But again, that's why I'm talking about this today, to hopefully get us thinking about that. That's also why, by the way, I put an article in your packets about Hippocratic prescribing. I also put an article in there, a little commentary about some of the critique of the thinking of that article to be fair and balanced. But I would urge you to consider reading that article. I think it offers some important perspectives on this whole business of, if you will, first doing no harm. Now, there are probably cultural habits at work too. You see on that slide the difference in polypharmacy practices in Denmark versus the United States. I don't know what the root causes of that are, but there are clearly both regional and probably international variations in these practices that probably have many root causes. Now, the next slide, we're looking at somebody named Henry Nasrallah offered 4 subtypes of polypharmacy that I think are a useful way to organize our thinking about it. So one subtype is necessary. Another one is reasonable. And what's the password there? Or is that something you have to shoot yourself?
Better not shout out loud across the room.
Rory is a jerk.
Just for demonstration purposes.
Oh, you didn't really mean that. She works with me enough to mean that. So we think we might have our slides back. Well, while we're getting them back, any questions up to this point? Comments? I've seen a few amens going on. Yeah.
I think part of the patient attitude issue is so many people have absorbed this idea that they have a chemical imbalance in their brains and that drugs don't decrease it.
Well, we've really sold that idea to people with good intentions, but these are some of the collateral problems. So where are we? All right, well, if we have time, I'll come back to the cartoons.
Where are we? Here we are.
Oh, there's a cartoon right there. But now how do I get this? Henry Nasrallah proposed these 4 subtypes. And I think the last 2 are obviously the ones that we really, really want to avoid. The ridiculous and the hazardous. And I'm sure as you're sitting here, you probably can all come up with some good examples of ridiculous and hazardous practices. But first, before we throw the baby out with the bath, let's talk about some of the necessary or reasonable ones. You can probably all come up with some necessary ones. Like the one I think about, for example, is we got an acute manic patient on the inpatient unit. And we know that it takes a while for the mood stabilizer to take effect. So we're going to use lithium. So we use a benzodiazepine or an antipsychotic, depending on your practice, to try to kind of quell a temporary mania until the mood stabilizer can take hold. And that's a necessary practice, arguably. And then you could come up with others. But what are some reasonable ones? Well, I came up with a few, looking at the literature, to use as examples. Some that you may be more or less familiar with. One of them is from a fairly recent study that was published in Lancet a couple of years ago. It was an international multi-center trial of patients with bipolar I disorder. And they were all given lithium or plus Depakote for their acute phase exacerbation. And those that tolerated it were then randomized later on to change to either lithium alone, Depakote alone, or continue the combination. And as it turned out, the combination was quite a bit better at preventing the next manic episode. This business about a number needed to treat, you can calculate that in a certain way from studies with the proper data. You'd have to treat about 7 patients to see 1 patient benefit from this intervention. That's what a number needed to treat means. And lithium alone was best at preventing depressive episodes. And this defends a lot of other information about lithium. So it led the authors to conclude that we ought primarily to be giving bipolar I patients who are manic lithium first, and if they fail, to add Depakote. That's probably the first thing we should be doing. That would be a reasonable polypharmacy. Now the next one, I knew I had to throw a few bones to the CD crowd here, even though I don't do a lot of CD. Well, I do a lot of CD work, but not primary CD work. The combination of naltrexone and gabapentin in the treatment of alcoholism. This too is a fairly recent study that was sponsored by the government, so ideally some of the biases are less introduced. These were mostly white middle-aged men who received the combination of naltrexone and gabapentin at 50 and 120 milligrams or less. And they had better outcomes at 6 weeks, meaning that they had a longer interval to heavy drinking and fewer drinking days when they were in the combination treatment. And that positive effect faded if you removed the gabapentin. So again, this would be an example of a potentially reasonable polypharmacy. Now, perhaps a more controversial practice is the use of benzodiazepines in the acute treatment of major depression. Now, some of you may have heard of a bunch called the Cochrane Group. This is a bunch of great wizards who do reviews, what they're called systematic reviews and meta-analysis, looking at large numbers of data and studies and kind of crunching that down into, what can we say about something. Now, there are a lot of problems with those methods too. You can introduce biases, it all depends on the quality of the studies and all that, but you can usually rely pretty well on a Cochrane review or meta-analysis. And what they did is they looked at all the studies that had data about the combination of benzodiazepine and an antidepressant in the acute treatment of major depression. And for those with prominent anxiety or insomnia as part of that presentation, the combination was highly favorable. The numbers needed to treat were 12 patients to benefit at 1 week, 9 at 2 weeks, and only 4 at 4 weeks. So within 4 weeks of that treatment, every 4th patient was significantly benefiting from that combination. The review concluded that the implications of the present meta-analysis for practice may be as follows. Unless you are a physician who's among the few who never prescribe a benzodiazepine, there are good reasons to consider adding a benzodiazepine to the antidepressant you prescribe to the next patient you see with major depression, especially if he or she shows some anxiety or insomnia, which many depressed patients do, after carefully balancing and discussing with the patient the available evidence for and against such a combination. Whether or not the potential harms of benzodiazepines are important enough to offset the benefits of combination therapy found in this review requires deliberation, both on the part of the physician and the patient. Individualizing the evidence to the particular patient, for example, with regard to potential of abuse, the possibility of developing discontinuation syndromes, and the probability of other harms, should be tried. So, even though these kinds of practices are somewhat controversial, we have a lot of differing opinions about the use of benzodiazepines. I wanted to include this, again, for fair and balanced reporting and to provoke some thinking and debate about the potential proper use of benzodiazepines. I'm not advocating that you necessarily do it in some of our patients, because there's a lot of potential harms here too, right? Not the least of which is diversion or misuse, the development of dependency or tolerance, the loss of effectiveness, which occurs. There's another concept called a number needed to harm. About 7 patients will develop loss of effectiveness with benzodiazepine use. Diversion, difficult discontinuation, that's about number needed to harm of about 40. Falls, the number needed to harm there is somewhere in the mid-100s. And motor vehicle accidents, which is around 3,000 patients for one to be harmed. So this is something that has to be done very deliberately, but again, would be an evidence of a rational and not a ridiculous practice. Now the next slide, the next 2 slides are about combining 2 antidepressants from the onset of treatment. One of the reasons why I decided to present this study, these 2 studies, was that the first one came out first. If I call it the first one, was a study that looked at the difference between using fluoxetine alone at 20 milligrams versus using it in combination at 20 milligrams with either Remeron or Effexor or bupropion Wellbutrin. In that study, which was published in 2009 in the American Journal of Psychiatry, they looked at the outcome by 6 weeks, and it looked as though the combination treatments were better. The critique of this study is that, first of all, if you know anything about Prozac, it has a very long half-life. So it takes a very long time to actually reach steady state, and 6 weeks is probably not an adequate treatment trial of Prozac. Plus, 20 milligrams may not, for many patients, be an adequate dose. So there was no arm that pushed time or the dose of Prozac. So this study was highly criticized, although some people jumped on it as an example of why prescribing 2 antidepressants at once from the initiation of treatment was maybe a grand idea. Along came a better study, published literally this month in the American Journal of Psychiatry, so I can't be accused of not being current today. That study randomized over 650 patients in both primary and specialty care to 3 arms. And so I forgot we can use slides. Well, yeah, I'll pause for the cartoon. It's 2 Godzillas eating people. It says, of course you feel great. These things are loaded with antidepressants. So if you look at this study, 650 patients given these combined treatments, Lexapro alone, Wellbutrin and Lexapro, or Effexor and Remeron, there's no difference here in both either the short term or long term. So this study really kind of kicked the leg out of this first study that suggested that combining antidepressants at the onset of treatment for depression is helpful. I think it's not something that I would recommend, although you can see that there are 2 studies showing different options here that you could grab hold of evidence. You'd have to decide for yourself which evidence is best.